Good day. Our topic for today is drug therapy for urinary tract infections. First, let us review the classification for your urinary tract infections. So, infections may be limited to bacterial colonization of the urine or bacteria and may invade tissues of the urinary tract. If there is inflammation of the urethra, it is called urethritis. Cystitis is inflammation of the urinary bladder, while your pyelonephritis is inflammation of the kidneys and its pelvis, and prostatitis is for your inflammation of your prostate. UTIs may be classified according to their location in either your lower urinary tract, such as your bladder or urethra, or your upper urinary tract. So, So urethritis and your cystitis are considered lower tract infections, while your pyelonephritis is considered an upper tract infection. UTIs are referred to as complicated or uncomplicated. Complicated UTIs occur in both males and females and are associated with some predisposing factor such as calculi or stones, prostatic hypertrophy, an indwelling catheter, or an impediment to the flow of urine. Example will be your physical obstruction. While your uncomplicated UTI occur most primarily in women of childbearing age and are not associated with any particularly predisposing factor. So the bacteria that cause your UTIs differ between community-associated infection and hospital-associated infections. In the majority, more than 80% of uncomplicated community-associated UTIs are caused by your Escherichia coli. Your Staphylococcus staphylococcus accounts for 10% to 15% of community-associated infections. Your hospital-associated UTIs are frequently caused by your Klebsiella, Proteus, Enterobacter, Pseudomonas, Staphylococci, and Enterococci, and E. coli is responsible for less than 50% of these infections. Acute cystitis is a lower UTI that occurs most often in women of childbearing age. Clinical manifestations are dysuria, urinary urgency, urinary frequency, suprapubic discomfort, pyuria, and bacteriuria of more than 100,000 bacteria per milliliter of urine. Now, for the treatment for uncomplicated cystitis, trimethoprim sulfamethoxazole are the drugs of choice for these UTIs. In communities where resistance to this drug is 20%, the fluoroquinolones, your ciprofloxacin or your levofloxacin, are good alternatives. When adherence is a concern, your fosfomycin is the required and the good choice. On the other hand, your acute uncomplicated pyelonephritis is an infection of the kidneys. The disorder is common in young children, older adults, and women of childbearing age. Clinical manifestations include fever, chills, severe flank pain, dysuria, urinary frequency, urinary urgency, and pyuria. And they have bacteriuria of more than 100,000 bacteria per milliliter of urine. So, for the treatment, your acute uncomplicated pyelonephritis for mild to moderate infection can be treated at home with oral antibiotics. Preferred options are your trimethoprim sulfamethoxazole or your cotrimoxazole, and the treatment should last for 10 to 14 days for your moderate to severe infection. So now, for your complicated urinary tract infections occur in males and females who have structural or functional abnormality of your urinary tract that predispose them to developing infection. Factors would include your prostatic hypertrophy, your renal calculi or stones, nephrocalcinosis, renal or bladder tumors, ureteric stricture, and an indwelling urinary catheter. The symptoms of complicated UTIs can range from mild to severe. Some patients even develop systemic illness such as fever, bacteremia, and septic shock. So the treatment for your complicated urinary tract infection includes your trimethoprim sulfamethoxazole, your ciprofloxacin, levofloxacin, amoxicillin clavulanate, and your cephalexin. Accordingly, if treatment is to succeed, we must determine the identity and drug sensitivity of the causative organism. To do so, urine for microbiologic testing should be obtained before giving any antibiotics. Now, for your recurrent urinary tract infection, your relapse is caused by recolonization with the same organism responsible for the initial infection, while your reinfection is caused by colonization with a new organism. Now, your prophylaxis for your recurrent infections will include your trimethoprim sulfamethoxazole, trimethoprim, and your nitrofurantoin. They are given for 6 months duration. Acute bacterial prostatitis means local bacterial infection in the prostate. Clinical manifestations include high fever, chills, malaise, myalgia, localized pain, and various urinary tract infections such as dysuria, nocturia, urinary urgency, urinary frequency, and urinary retention. For severe infection with E. coli, treatment starts with an IV agent fluoroquinolone, such as your ciprofloxacin, followed by 6 weeks with an oral agent such as your trimethoprim sulfamethoxazole or a fluoroquinolone. Now, for severe infection with vancomycin-sensitive E. fecalis, treatment starts with ampicillin sulbactam, followed by 6 weeks with PO amoxicillin, levofloxacin, or your doxycycline. So we have two urinary tract antiseptics, your nitrofurantoin and your methenamine. So both are used only for UTIs. These drugs become concentrated in the urine and are active against the common urinary tract pathogens. Neither drug achieves effective antibacterial concentrations in blood or tissues. So your nitrofurantoin is the first choice drug for your uncomplicated cystitis. So your nitrofurantoin has bacteriostatic effects at low concentration and bactericidal effects at high concentrations. It injures bacteria by damaging your DNA. It's selectively toxic to bacteria because, unlike mammalian cells, bacteria possess relatively high levels of the enzyme needed for drug activation. So your nitrofurantoin is active against large number of gram-positive and gram-negative bacteria. Susceptible organisms include your Staphylococci, Streptococci, Neisseria, Bacteroides, and most strains of your E. coli. So the adverse effects of your nitrofurantoin is your gastrointestinal effects. The most frequent adverse include your anorexia, nausea, and vomiting. We also have pulmonary reactions. We have two types, your acute and your subacute reactions. Acute reactions are most common, which manifest as dyspnea, chest pain, chills, fever, cough, and your alveolar infiltrates. Then your subacute reactions are rare and occur during prolonged treatment. Symptoms include your dyspnea, cough, and malaise, and it usually regress over weeks to months. And it also has hematologic effects. So there will be hemolytic anemia may occur in infants and in patients whose red blood cells have an inherited deficiency in your G6PD or your glucose 6-phosphate dehydrogenase. Your nitrofurantoin can also cause peripheral neuropathy, so damage to sensory and motor nerves is a serious concern in your nitrofurantoin. Nitrofurantoin is also hepatotoxic, but rarely it only causes severe liver injury manifesting as hepatitis, cholestatic jaundice, and your hepatic necrosis. And it can also cause your birth defects. Because of the possibility of hemolytic anemia, the drug is contraindicated in pregnant patients at term 38 to 42 weeks gestation. And also, it has central nervous system effects. So nitrofurantoin can cause multiple CNS effects such as your headache, vertigo, drowsiness, and nystagmus. All are reversible in all these adverse effects are reversible once we stop taking nitrofurantoin. Now, your methenamine The mechanism of action is a prodrug that under acidic conditions breaks down into ammonia and your formaldehyde. So your formaldehyde denatures bacterial proteins causing cell death. Now, so for formaldehyde to be released, the urine must be acidic, pH of 5.5 or less. Since formaldehyde is not formed at physiologic systemic pH, methenamine is devoid of systemic toxicity. So virtually all bacteria are susceptible to formaldehyde and there is no resistance. So methenamine is used for your chronic infection of the lower urinary tract. And thank you for listening.